Oh, strap yourselves in, ladies and gents, because this is this is going to be a big one. This is all the muscles that some of which were discussed last week but not included in the lecture, and we're going to go right down from the hip to the foot, and this will give you a good idea of all the different muscles that would have atrophied in the time that Shannon was immobile. No time to lose, let's get started. Primary hip flexor, this is one of your readings for last week. We've got two. We've got the iliacus and the psoas muscle. Psoas we've met before. So the iliacus goes from the iliac fossa, so that's its proximal attachment. Proximal attachment of the psoas is from the vertebral bodies and the intervertebral discs of L1 to L4. They meet in a common tendon as they pass through the subinguinal space. Okay, so this is another structure that passes through the subinguinal space, and the distal attachment is on the lesser trochanter. So the actions, well, if the lower limb is free to move, then it will be a hip flexor, and some would argue an external rotator of the hip as well. But if the femur is stable, so the lower limb is planted on the ground, then it becomes a spinal flexor, a lumbar spine flexor, and lastly, it's innervated by the femoral nerve. Cool. Other weaker hip flexors. Sartorius. We've talked about sartorius before because it forms a lateral border of the femoral triangle. Proximal attachment. ASIS. Distal attachment. Superior part of the medial surface of the tibia at a region, and you will need to know this, called the pes anserinus. The pes anserinus. Tensor fasciae lata. External surface of the ilium, part of the ASIS, and where it will insert distally, so that's the proximal attachment, where it will insert distally is actually on Gerdy's tubercle. Now we talked about Gerdy's tubercle right at the start. Pectineus goes from the pecten pubis proximally to the pectineal line of the femur. The pectineus is a weak adductor and it's a weak hip flexor. So weak hip adductor and weak hip flexor. Sartorius has a really complex action. It's a hip flexor, abductor, and external rotator. Flexor, abductor. Let me try that again. Hip flexor, hip abductor, and hip external rotator. So you can remember it as the Faber muscle. F-A-B-E-R. Flexion, abduction, external rotation. Tensor fasciae lata. It's really a weak abductor. And it tenses, as the name would suggest, the fascia lata. But it's a weak abductor. Rectus femoris. Rectus femoris is going to be one of the four quadriceps. What does it do? Well, it flexes the hip weakly and it extends the knee. So you can imagine if you're kicking a footy, for example, you're flexing the hip and extending the knee and using a lot of rectus femoris strength. So that goes from the AIIS proximally to the tibial tuberosity distally. Now, all of these, except for the tensor fasciae lata, are innervated by the femoral nerve. Tensor fasciae lata is innervated by the superior gluteal nerve. Let's move on. Gluteals. Gluteus maximus. Proximal attachment, posterior ilium. And some of you may have read in Gray's Anatomy, and it's fine if you do, it probably says something like posterior to the gluteal line of the gluteal surface of the ilium. If you want to remember that, brilliant. Will it get you extra marks? Not in this unit. It's fine just to remember posterior ilium. Distal insertion, gluteal tuberosity. Remember, that's the proximal extension of the linea aspera. Innervation, inferior gluteal nerve. What does it do? Well, it's the main hip extensor. It's the prime mover of hip extension. Also some external rotation. Main hip abductors are the gluteus medius and minimus. both from the lateral ilium on their proximal attachment. Distal attachment is on the greater trochanter. Do you need to know whereabouts on the greater trochanter? No. Don't worry about it for this unit. Innervation, superior gluteal nerve. And as I said, abductors of the hip. Iliotibial tract. Often on diagrams, anatomical diagrams, it will show the iliotibial tract as a independent structure. It's not. It's actually just a thickening. It's an artificial structure that we've sort of dissected away and to make it look pretty, but really it's a thickening of a fascia called the fascia lata. Now, it will support the lateral side of the knee, so it will resist varus forces, so it will brace the lateral knee, and it also assists to compress the muscle compartment of the thigh. And in doing so, it will assist in venous return. And there's other reasons why you may want to increase muscle pressures, but that's out of the scope of this unit. We've talked about the tensor fascia lata. So it's an abductor, and it may, when it tenses the iliotibial tract, as the name would suggest, tensor fascia lata, it may actually stabilize the lateral knee. That's a little bit speculative. We don't know that for sure, but it has been speculated as one of its functions. So superior gluteal nerve. Here we have small external rotators, and there's actually 6 of them. And their proximal attachment is around the different bones of the os cox. But let's go through them, okay? Just generally. So piriformis is going to have its proximal attachment on the anterior surface of the sacrum. The superior gemellus is going to have its proximal attachment at the ischial spine. Obturator internus is going to have its proximal attachment on the internal surface of the obturator membrane and the obturator foramen. The inferior gemellus is going to have its proximal attachment on the ischial ramus, as is the quadratus femoris, also has its proximal attachment on the ischial ramus. Where do they all insert? Well, they all insert around the greater trochanter and intertrochanteric crest. If you give me either of those as their distal attachment, I'll be very happy. They're all supplied by small branches from the lumbar plexus, which is the plexus, as you know, that innervates the lower limb. And you don't need to worry about each one of these levels, okay? Don't worry about that. What are they? They're external rotators, but they're sort of akin to the rotator cuff muscles of the glenohumeral joint. They are actually going to serve to stabilize the femoral head within the acetabulum. So they're going to compress that femoral head within the cup that is the acetabulum, muscles of the thigh. It's important you understand the compartmentalization of the muscles of the thigh. And we'll go through that here. Anteriorly, we have the quads and sartorius. So if it's in the anterior compartment, it's going to be a flexor of the hip and an extender of the knee, or extensor of the knee, I should say. The medial compartment is the hip adductors, which is going to do adduction of the hip. Posteriorly, this compartment that you can see here, these are the hamstrings, and they're going to extend the hip, and they're also going to flex the knee. But it's important you understand these compartments because you can see these compartments very clearly, not only on CT scans, but also on MR scans as well. And please just note that there are fascial containers containing each one of these compartments. And those fascial containers have their names, but we don't need to worry about those. Cool. So let's have a look at the muscles of the anterior compartment. So we see here 3 of the 4 quadriceps. We've met the rectus femoris before, okay? Now the vastus lateralis is here, okay? And this will actually attach all the way back from the lateral lip of the linea aspera. And the vastus medialis is vast and is going to attach from the medial lip of the linea aspera. Now, these two vastus muscles don't actually cross the hip, so they can't act on the hip because a muscle has to cross a joint in order to act on it. And they will come together with the rectus femoris tendon to form the common quadriceps tendon. However, they're not quite finished yet because the tendon will actually cross over and some would argue through the patella, and that's a long story. And so the quadriceps muscles all have a common insertion onto the tibial tuberosity, and you do need to know that. So all the quadriceps insert on the tibial tuberosity. Sartorius, as we said, ASIS, all the way down to the pes anserinus, and we've discussed the motion, the complex motion that the sartorius has. Here's a deeper section. We've cut away, as you can see, the rectus femoris. Here's the tendon, proximal tendon of the rectus femoris. You can see that because it's going to attach onto the AIIS. And here we can see the fourth muscle of the quadriceps, hence the name quadriceps. So 4 of them. This is the vastus intermedius. So again, we've had the vastus lateralis, vastus medialis, vastus intermedius, so it's sandwiched in an intermediate position, and rectus femoris over the top. Rectus, if you remember, means straight, so it's a muscle that goes straight down over the femur. Note, the 3 vastus muscles do not cross the hip. All of them attach to the tibial tuberosity and therefore act in knee extension. All of them. Cool. Quadriceps, in its own little compartment, is innervated by the femoral nerve, as is the sartorius, as is the pectineus muscle. Pectineus is a strange muscle. Why? Because the pectineus is probably best classified as a medial compartment muscle, but it's innervated by the femoral nerve. So, adductor muscles, where do they originate from and where do they insert from? Well, they all originate somewhere around the pubic bone, and they all insert somewhere around the linea aspera, except for the gracilis, which inserts below the knee at the pes anserinus. They're all supplied by the obturator nerve, except for the pectineus. So we've talked about the pectineus. It goes from the pecten pubis on the superior pubic ramus of the pubic bone down to the pectineal line of the femur. Weak flexor, weak adductor of the hip. Here we have the adductor brevis that you can see here. And the adductor brevis will go from the body of the pubis down to the proximal linea aspera. Whereas the adductor longus, and we'll remember the adductor longus because it forms the medial part of our femoral triangle, will actually be anterior to the adductor magnus and will go from the body of the pubis, and it will go down to the middle third of the femur. This is the way that you can identify the adductor longus, because no other muscle goes down to the middle third of the femur. Okay? Adductor magnus is this big one. How can you identify it? Well, it's going from the inferior pubic ramus. It's the only one that has its sole proximal attachment from the inferior pubic ramus, and it's also the only one that has its full extent from the linea aspera right down to the adductor tubercle. It is also the only one with a hiatus, and we met hiatuses before. In the diaphragm, remember we saw the aortic hiatus and the esophageal hiatus. Well, now this is the adductor hiatus, and we've got several structures that go through there. We'll discuss that later. One we've already discussed, and that's the femoral artery. And gracilis is medial, but we don't actually have the gracilis on this picture, but it's going to go from the body of the pubis down to the pes anserinus. All of these are adductors. All of them except pectineus are innervated by the obturator nerve. Muscles in the posterior compartment. A true hamstring will do two things. A true hamstring will cross the hip joint posteriorly, and it will also cross the knee joint. Now, it will a third requirement for a hamstring is it will originate proximally on the ischial tuberosity. The short head of the biceps femoris isn't a true hamstring, but we'll talk about it anyway. So let's have a look at them. So let's start off with the biceps femoris. Now this has to be, of course, differentiated from the biceps brachii, and I'm sure some of you have been thinking, do I have to call it the biceps brachii? Well, yes you do, because biceps brachii is referring to it as the two-headed muscle of the brachium. The biceps femoris is referred to as the two-headed muscle of the femur. So this is to differentiate it between each other. Biceps femoris, two heads. Long head from the ischial tuberosity. Short head from the linea aspera all the way down to the supracondylar line. They have a common distal insertion, distal attachment at the head of the fibula, down here. What do? Collectively? Extend the hip, flex the knee, because they're a hamstring. Brilliant. Semitendinosus, semimembranosus. How are you going to remember these? Well, semitendinosus ends distally in a tendon that you can see here. So here's the semitendinosus tendon. Now the semimembranosus that you can see here, semimembranosus, is going to end in a thickened tendinous membrane, so it looks more membranous. The other way you can remember it is semimembranosus is more medial. Membranosus medial than the semitendinosus. Proximal attachment, ischial tuberosity, distal attachment. Semitendinosus will go down to the pes anserinus. Pes anserinus. Okay? So there's three things now inserting onto the pes anserinus. That's the sartorius, the gracilis, and the semitendinosus. In that order from anterior to posterior. So some people like to remember it as say grace before T. So say, sartorius, grace, gracilis before T, semitendinosus. Cool. Semimembranosus. It goes down to the medial tibial condyle. So what does it do? Well, it's going to extend the hip, flex the knee, like the other hamstrings. All of the hamstrings, and you do need to know this, are supplied by the sciatic nerve. The muscles of leg and foot. These two are compartmentalized. What can we see here? We're looking at an inferior view of the leg. This is the tibia. You notice the thickened shaft. This is the fibula. This is going to be the interosseous membrane between here. And then we have two fascial thickenings. We have one called the anterior crural septum and another called the posterior crural septum. Now between the tibia and the anterior crural septum, we have the anterior group of muscles of the leg. Between the anterior and posterior crural septae, we have the everter or lateral group of muscles. Between the interosseous membrane and the transverse septum, we have deep flexors. And then between the transverse septum and the superficial fascia, we have superficial flexors. And these are going to be our plantar flexors. So let's have a look at them. So in our anterior compartment, we have a Tom, a Dick, and a Harry. Tibialis anterior, extensor digitorum, longus, and extensor hallucis longus. Let's have a look at them. The innervation for these are the deep fibular nerve. Right, so tibialis anterior, that's this one just here. Tibialis anterior is going to go from the medial surface of the tibia down towards the first cuneiform. What's it going to do? Well, it's going to dorsiflex the foot. It's a prime mover of dorsiflexion, and it's going to invert very well. The extensor hallucis longus is going to insert distally on the distal phalanx of the first digit. The extensor digitorum longus is sort of analogous to the extensor digitorum of the forearm, and it's going to go down to the 2nd to 5th digits, and it's going to extend the 2nd to 5th digits at the distal and proximal interphalangeal joints. So tibialis anterior we've talked about, and it's going to work with the tibialis posterior to invert the foot. If you see weakness in dorsiflexion of the foot, then often the culprit is going to be the tibialis anterior. Let's have a look at the tendinous insertions of these more clearly. Here we can see the tibialis anterior coming down to the first cuneiform, or the medial cuneiform, whichever you want to call it, extensor hallucis longus coming down to the distal phalanx, and extensor digitorum longus coming down to the 2nd to 5th distal phalanges to extend them. Right, lateral group, fibularis longus or fibularis brevis, also known as the peroneus longus or peroneus brevis. Fibularis is the Latin and peroneus is the Greek. Note that the fibularis longus is the lateral most muscle in the everter compartment, and brevis is the medial. They're both innervated by the superficial fibular nerve. Let's have a look. Here's the fibularis longus, and you can see that it comes posterior to the lateral malleolus, and then it dives medially under the foot, and it comes down to insert on the base of the first cuneiform and the first metatarsal. So what this is going to do is it's going to evert the ankle, mostly at the subtalar joint, and it's going to plantar flex the foot. Now the fibularis brevis is going to come down and it's going to originate from the lateral surface of the fibula, and it's going to insert distally on the styloid process of the 5th metatarsal. Okay, so lateral base of the 5th metatarsal is okay, but we really need the styloid process to be on there as well. Okay, styloid process. And this is really important to know, because in an inversion ankle sprain, often we can get fractures of the styloid process of the 5th metatarsal, because the fibularis brevis tendon will actually pull that bone away as it gets stretched. Both of these muscles have vital roles in ankle stability, in controlling inversion. So it resists inversion and controls it. Posterior muscles. Posterior compartment, we have the gastrocnemius and the soleus. We have the lateral and medial head of the gastrocnemius. And then deep, we have the soleus muscle. Both of these are innervated by the tibial nerve. So if we have a look here, the superficial group comprises of the 2 large plantar flexors and a small plantaris muscle, which we'll see in a second. Gastrocnemius is a 2-joint muscle. So you can see here's the medial head, here's the lateral head, and it's going to cross over the posterior aspect of the knee, which means it's going to act on the knee as well. So the gastrocnemius tendon is actually going to form the calcaneal tendon along with 2 other muscles, and it's going to insert onto the posterior aspect of the calcaneus at the calcaneal tuberosity. And 2 other muscles, as I said, contribute to the tendon, to the calcaneal tendon. We'll see that in a second. So the other muscle that contributes to the calcaneal tendon is the soleus muscle, which is here. And there's one more that contributes to the calcaneal tendon, and about 15% of people don't have this muscle, okay? But it's important for the 85% of us who do, because it can be easily ruptured, and this is the plantaris muscle. And these will go down to form the calcaneal or Achilles tendon. Achilles is a bit of an old term, but you'll still use it clinically. Almost everyone uses it clinically. But it's important to know those three muscles. So 3 muscles contributing to the calcaneal tendon: the gastrocnemius, the soleus, and the plantaris. Gastrocnemius will be a flexor at the knee and a plantar flexor at the ankle. Soleus and plantaris will both be plantar flexors. Cool. What else do we have? Posterior compartment. These are plantar flexors, and they will also act on the feet. So we have more Tom, Dick and Harry. We have tibialis posterior, we have flexor hallucis longus here, and we have flexor digitorum longus here, all innervated by the tibial nerve. So let's look at the deep flexor compartment. Again, Tom, Dick and Harry. Tibialis posterior. How are you going to identify the proximal attachment of tibialis posterior? What I look for is it being the centermost muscle. Okay, so it's directly posterior, as you can see here. It's directly posterior to the interosseous membrane there. So that's how I identify tibialis posterior. It's going to go down distally to insert onto the navicular tuberosity, as well as a bunch of other points. It's one of the most variable tendons in the body, but its most consistent insertion is onto the navicular tuberosity. Flexor digitorum longus. How are you going to identify the FDL? Well, it's on the medial most side of the leg. Flexor digitorum longus. Where's it going to go down to? Distal phalanges of digits 2 to 5 to flex the proximal and distal interphalangeal joints of digits 2 to 5. Flexor hallucis longus. How are you going to identify this? Well, it has its proximal attachment at the fibula, and you can see that here. Here rather. And here's the fibula. So flexor hallucis longus has its attachment to the posterior aspect of the fibula. And here it is. It's going to go down, and these tendons have a really weird arrangement, but it's going to go down and it's going to flex the interphalangeal joint off the big toe, off the great toe, of the first toe, whatever you want to call it. Cool. Also found deep in the knee is the popliteus. It attaches from the lateral condyle of the femur and the lateral meniscus, but quite weakly, inserts onto the posterior surface of the tibia. Its main function is to unlock an extended knee. It externally rotates a little bit and allows movement there again. Innervation is by the tibial nerve. There's 4 layers of muscles in the foot. Do I expect you to know any of them? No. Absolutely not. Not at this stage. Okay? There's too many, it's too complicated, and that's why we have podiatrists for, because they train for 4 very long years to learn all of these little muscles. If you're interested, go ahead and look at them. If you're not, don't worry about them. But you should know that there's 4 layers and they have a collective function. And the collective function of these muscles are to manipulate the toes, so someone will extend and flex the toes. And the other function of the muscles is to mold the foot to its terrain. And so this is quite interesting, because if you think about someone with diabetes, for example, who's got a peripheral polyneuropathy, then they can't feel the base of their feet anymore, and they don't know quite what terrain they're walking on. Therefore, the brain doesn't receive that sensory information, can't tell the muscles what to do, what kind of terrain they're walking over. Therefore, the muscles just assume that the terrain's flat and we're doing no damage because we can't feel pain. And this ends up causing a lot of major problems for the diabetic foot. We can get ulceration on there, we can get fractures, we can get unexpected bruising and joint deterioration. And this is all because the little muscles of the foot aren't responding appropriately to sensory stimulation because we can't feel sensory stimulation. So hopefully this illustrates the function of these intrinsic muscles of the foot, and that's to adapt the foot to the terrain we're walking on so we don't injure ourselves. Now that, ladies and gents, is going to be the longest mini lecture of the semester, and thank you very much for putting up with me for that. I know it's a lot of information. Only one more to go.